Imagine taking a medication that is specifically prescribed to protect your body, but within like a matter of days, you experience this sudden blinding rage.
Oh, yeah, or a crippling brain fog that makes it, impossible to even remember your own computer password.
Right. And for a highly sensitive minority of menopausal women, the standard treatment that is designed to alleviate their symptoms actually becomes the poison. So, welcome to another deep dive.
Glad to be here.
Today, we are exploring a reality that often gets swept under the rug, which is that menopause care is, well, it's not a one-size-fits-all flowchart.
No, definitely not.
I mean, most of the time, your general practitioner is perfectly equipped to manage the symptoms. But there are highly specific, incredibly nuanced situations where the standard medical playbook just completely falls apart.
And knowing when that happens is crucial though. It's the difference between months of debilitating trial and error and actually getting targeted, effective care.
Exactly. So we are zeroing in on the absolute boundaries of primary care today.
Yeah, we want to answer a very specific question. Exactly when should a general practitioner refer a menopausal patient to a specialist, gynaecological endocrinologist, or, a dedicated menopause clinic?
And to answer that, we are leaning on the definitive clinical guidelines. We've got documents from the National Institute for Health and Care Excellence, so INSE, the British Menopause Society, and several NHS trusts.
And when you actually sit down and read these documents, you realize they aren't just polite suggestions.
No, they're strict clinical safety nets.
Exactly.
So we are going to decode 4 major referral triggers today. And the first one actually has nothing to do with what symptoms a person is experiencing. It's all about when they are experiencing them.
Right, the timeline anomaly. The medical term for this is premature ovarian insufficiency, or POI.
POI, okay.
Yeah, and this describes the decline of ovarian function in a woman who is under the age of 40.
Under 40.
Yeah. And if this same decline happens just slightly later, so between 40 and 45, the guidelines categorize it as early menopause.
See, the numbers in the sources really caught my attention here, because POI affects roughly 1% of women under 40.
Which is significant.
It really is. And globally, some estimates actually push that prevalence closer to 3.5%.
Yeah, it's not some incredibly rare 1 in a million medical mystery.
Right. You probably know someone dealing with this, whether they have the official diagnosis or not. So let's unpack this terminology, because the guidelines make a very deliberate point of abandoning the old phrase. People used to call it premature ovarian failure.
Yes, and the word failure carries a heavy, almost devastating psychological weight.
It sounds so final.
It does. It implies a door slamming shut forever, like a permanent, irreversible cessation of all function. But biologically speaking, that is a completely inaccurate description of what's actually happening inside the body.
How so?
Well, in POI, the ovaries do not simply power down like a machine being unplugged from the wall. In fact, up to 50% of women with POI will continue to experience intermittent menses.
Okay, so it's less like a light bulb burning out completely and more like, I don't know, a light bulb flickering on a faulty circuit.
That's a great way to put it. The power surges, it drops, it goes dark for a while, and then suddenly it sparks back to life.
But that flickering mechanism, that has to make it incredibly difficult for a general practitioner to pinpoint, right?
Oh, absolutely.
Like, if the ovaries are just sputtering, how does a doctor catch it without just writing it off as missed periods due to stress or weight loss or just an irregular cycle?
Well, that erratic biological behavior is the core of the diagnostic challenge. To establish POI, the clinical guidelines instruct GPs to look for a specific pattern.
Which is what?
Amenorrhea.
Yeah.
So the complete absence of periods for at least 4 consecutive months.
Okay, 4 months.
But a patient's history isn't enough on its own. It has to be backed up by blood work. Specifically, they need 2 tests measuring follicle-stimulating hormone, or FSH.
Right.
And those 2 tests must be drawn 4 to 6 weeks apart.
Because measuring it once might just catch the light bulb during a momentary flicker.
Right. Exactly.
The hormone levels are bouncing around, so a single snapshot tells you absolutely nothing reliable.
Exactly. The 4 to 6 week gap accounts for that fluctuation. So if the FSH levels are significantly elevated on both tests, and you pair that with the 4 months of missing periods, the diagnosis points firmly to POI.
But the guidelines draw a very hard line here regarding uncertainty, don't they?
They really do. If the GP encounters conflicting blood work, say, they decide to test anti-Müllerian hormone, AMH, and the results just don't align with the FSH levels, they must refer the patient to a specialist.
Because primary care just isn't the venue for untangling those conflicting endocrine signals.
No, it's not. AMH doesn't even have a reliable diagnostic cutoff for POI in primary care.
Wow. And, understanding why this mandate exists is terrifyingly important. Missing this diagnosis isn't just about a patient suffering through early hot flushes.
Not at all.
The downstream health consequences of living without estrogen for an extra decade or more are severe.
We are talking about critical systemic aging. I mean, estrogen is profoundly protective. Without it, the arterial walls lose their elasticity.
Which drastically increases the risk of early cardiovascular disease. Right?
Exactly. And bone turnover accelerates. It pulls calcium out faster than it can be replaced, which sets the stage for severe osteoporosis.
It's scary.
It is. There's also emerging data linking untreated POI to early cognitive impairment. So the guidelines mandate that these women require hormone replacement therapy or a combined oral contraceptive at minimum until the natural average age of menopause.
Which is 51.
Right.
So it's pure structural preservation.
Yeah.
You are artificially replacing the foundation that the body just stopped producing prematurely.
Yes. And we have to factor in the sheer psychological trauma of this diagnosis.
Oh, I can't even imagine handing a POI diagnosis to a 32-year-old who hasn't even started a family yet. That is a massive psychological blow.
And a standard 10-minute GP appointment is not built to absorb that kind of emotional or medical shockwave.
No way.
Specialist clinics operate on a multidisciplinary model. They integrate clinical psychologists to handle the grief, endocrinologists to balance the complex hormone replacement, and specialized fertility services.
Because fertility is still a factor.
Yes, women with POI actually maintain a 5 to 10% chance of spontaneous pregnancy, but traditional IVF using their own eggs has a very low success rate.
Right. So navigating that requires a highly specialized team.
Absolutely.
Okay, so we've looked at what happens when the timeline is abnormal, when the body stops producing hormones far too early. But what happens when the timeline is perfectly normal, but introducing standard HRT into the body is essentially like throwing a match onto a gasoline spill.
That is a great analogy.
Thanks.
Yeah.
That brings us to our second major referral trigger, navigating a complex medical canvas.
Right. We're entering the territory of high-risk comorbidities. The major red flags here are a personal history of hormone-dependent cancers, so specifically breast or ovarian cancer, or carrying high-risk gene variants like the BRCA mutations.
Or having a significant history of blood clots, like venous thromboembolism or strokes.
Exactly.
Here is where it gets really confusing for a lot of people. I mean, if someone has survived an estrogen receptor-positive breast cancer, I would assume giving them estrogen through HRT is just an absolute non-negotiable no.
A lot of people think that.
Right. Like, why involve a menopause specialist if the treatment is fundamentally off the table anyway?
Well, that assumption is incredibly common, even among some medical professionals. But it lacks the microscopic nuance that oncology requires. A history of breast cancer does not automatically trigger a blanket ban on all menopausal treatments.
Wait, really?
Yeah, the type of cancer therapy the patient is currently taking dictates everything.
Okay, let's break down how those therapies actually work then, because clearly the mechanisms matter.
They do. Take tamoxifen versus aromatase inhibitors. Those are two very common breast cancer treatments. Tamoxifen works by binding to the estrogen receptors in the breast tissue. It blocks estrogen from attaching and fueling cancer growth.
Okay, that makes sense.
But interestingly, in other parts of the body, like the uterus or the bones, tamoxifen can actually mimic the effects of estrogen.
Oh, wow. So it's like a selective blocker. It locks the front door at the breast tissue, but it leaves the back door open elsewhere.
Exactly. Now, aromatase inhibitors operate on a completely different principle. They don't block receptors. They shut down the body's actual production of estrogen outside of the ovaries entirely.
So they just starve the entire system of the hormone.
Yes. Now, why does this matter for menopause care? Because up to 70% of women on these cancer drugs suffer from severe genitourinary syndrome of menopause.
Which is extreme vaginal dryness, pain, and urinary issues.
Right. And the guidelines say that vaginal estrogen, which is applied locally, can often be used safely for a patient on tamoxifen.
Because vaginal estrogen has minimal absorption into the systemic bloodstream, and the tamoxifen is already guarding the breast tissue receptors anyway.
Precisely. But for a patient on an aromatase inhibitor whose entire survival depends on keeping systemic estrogen levels at absolute zero,
even that tiny microscopic absorption from vaginal estrogen is generally considered too dangerous.
Exactly. A general practitioner simply cannot be expected to orchestrate the chemical interactions of complex oncological drugs. A specialist must step in, consult directly with the patient's oncologist, and map out a safe pathway.
And if hormonal options are entirely ruled out, the specialist has a secondary toolkit of non-hormonal medications,
What do
right?
you do?
The sources list things like NK3 receptor antagonists,
Yeah.
drugs like fezolinetant, and this is fascinating science. Instead of replacing hormones, it targets the literal temperature control center in the brain.
It's incredible.
It blocks the specific neurokinin receptors that misfire and trigger hot flushes when estrogen drops. It basically fixes the faulty thermostat without adding a drop of estrogen to the body.
The specialist might also utilize certain SSRIs or SNRIs like venlafaxine or even nerve pain medications like gabapentin.
Because they have proven efficacy in dampening vasomotor symptoms off-label. But what happens when the non-hormonal options just don't work? Because the literature points out a pretty devastating reality. The menopausal symptoms caused by these cancer treatments can be so horrific, so destructive to a woman's quality of life, that they actually stop taking their life-saving cancer medication just to find relief.
And that is the ultimate high-stakes tightrope walk. If a patient is threatening to abandon their oncology protocol because they cannot endure the hot flushes or the psychological toll, a menopause specialist has to intervene.
It's literally a matter of life and death.
It is. In very rare, highly controlled cases, after exhausting every non-hormonal avenue, the specialist, the oncologist, and the patient will sit down and weigh the survival benefit of the cancer drug against the risk of introducing systemic HRT.
Wow. Balancing quality of life against recurrence risk.
Exactly. That conversation alone mandates the highest level of specialist expertise.
Which brings us to a completely different kind of challenge. We've talked about a lack of hormones and the danger of adding hormones to a cancer history. But what if the patient is healthy, they are the right age, they have zero complex medical history, the general practitioner prescribes the gold standard HRT.
And it all goes wrong.
Right. And the patient's own brain turns it into a nightmare.
Yeah, we are looking at treatment failure here, specifically driven by a phenomenon known as progesterone intolerance.
This is where we see the symptoms I mentioned at the very beginning of the deep dive. The severe bloating, the intense fatigue, and most alarmingly, the psychological chaos.
The sudden depressive crashes or sheer rage.
Yes, and the definitive clue is the timing, right? These symptoms reliably spike the exact moment the patient starts the progesterone phase of their HRT, and they evaporate the moment they stop.
Exactly. To understand why this happens, we have to look at the neurology of hormone metabolism. When we prescribe HRT to a woman who still has her uterus, we must include progesterone.
Because estrogen thickens the lining of the womb and progesterone sheds it, protecting against endometrial cancer.
Right, it's the biological groundskeeper.
But why is the groundskeeper setting fire to the brain?
Because of how the brain processes that hormone. When progesterone enters the body, it breaks down into a metabolite called allopregnanolone.
Okay.
This metabolite travels to the brain and binds to the GABA receptors.
And GABA is our primary inhibitory neurotransmitter. It's basically the brain's braking system.
Exactly. In the vast majority of the population, when allopregnanolone binds to that GABA receptor, it acts like a mild sedative. It produces a calming, stabilizing effect.
Okay, so what goes wrong for the others?
Well, in a sensitive minority of women, frequently those who have a documented history of severe premenstrual syndrome, premenstrual dysphoric disorder, or severe postnatal depression, the mechanism backfires.
So it's a lock and key system, but it's wired backward. The key fits perfectly into the GABA lock, but instead of turning on the calming system, it trips the emergency alarm.
That's it, exactly. Their unique neurochemistry misinterprets the metabolite, provoking acute anxiety, irritability, and mood swings.
And the clinical challenge there is profound, because, as we established, if the patient has a uterus, they cannot simply stop taking progesterone.
No, the risk of endometrial cancer is just too high. A general practitioner can attempt initial adjustments, but the clinical guidelines establish a very firm boundary. If a patient fails to tolerate 3 different progesterone preparations, trying each for 3 months, the GP must refer them to a specialist.
So 9 months of trial and error is the absolute maximum limit.
Right.
Once they reach the specialist, what does the toolkit look like? because the specialist still has to protect the womb.
Well, the specialist can manipulate the delivery system and the chemical structure of the hormone. They will often immediately transition the patient away from older synthetic progestogens toward body-identical micronized progesterone.
Oh, interesting.
Yeah, it exactly mimics the molecular structure produced by the human ovary and often results in a vastly different metabolic breakdown.
So it's basically changing the key to see if the lock responds better. What about bypassing the bloodstream altogether?
That's a highly effective strategy. The specialist might utilize a levonorgestrel-releasing intrauterine system.
So the Mirena coil.
Exactly. This device sits directly inside the uterus, releasing the progestogen locally right where it is needed to protect the endometrium.
And the genius there is that the hormone stays highly concentrated in the womb, but the systemic levels floating around in the bloodstream and making their way up to the brain remain incredibly low.
Right. It effectively silences the neurological side effects while maintaining the physical protection. The specialist might also alter the dosing schedule, tweaking the regimen from a continuous daily dose to a modified sequential one.
Which gives the GABA receptors a necessary break.
Exactly. It requires a level of bespoke pharmacological tailoring that just falls well outside a primary care remit.
Well, mood changes and psychological side effects offer a little bit of breathing room to adjust dosages and try new methods. But our final referral trigger offers absolutely no such luxury.
No, it doesn't.
It is a physical symptom that acts as a strict, timeline-driven ticking clock for both the patient and the physician. We need to talk about unscheduled bleeding.
This is the ultimate red flag in menopause care. Unscheduled bleeding demands immediate, specific diagnostic action because it is the primary physical warning sign for endometrial hyperplasia.
Which is the abnormal overthickening of the womb lining, right?
Yes, or it could be a sign of endometrial cancer.
Now, the guidelines do offer a small window of grace here. They acknowledge that erratic bleeding is actually incredibly common in the first 6 months of starting HRT, or, changing a dose.
Because the body is essentially recalibrating to the new hormone levels.
Right. But the absolute line in the sand is that 6-month mark. If unscheduled bleeding persists past 6 months, or if it is excessively heavy, or occurs in patients with high-risk factors like a BMI over 40, the GP must escalate the case.
They have to.
But why is 6 months the universal cutoff? I mean, we know human bodies aren't machines, right? They don't run on exact 6-month timers.
True, but the 6-month cutoff is a calculated clinical safety net. Yes, bodies adjust at different rates, but allowing unexplained bleeding to continue beyond half a year without visually inspecting the inside of the uterus, that tips the scale from a likely adjustment period to clinically unsafe negligence.
Wow.
The risk of missing a developing malignancy just becomes too great.
So when the referral is made, the investigative tools shift from symptom management to hard visual metrics.
Exactly.
The standard procedure is a transvaginal ultrasound, which allows the specialist to measure the endometrial thickness, or ET. And the parameters they use are incredibly precise, aren't they?
Oh, very. The diagnostic thresholds depend entirely on the specific type of HRT the patient is using. So if a woman is on continuous combined HRT, meaning she takes both estrogen and progesterone every single day, which should theoretically keep the lining permanently thin, an endometrial thickness greater than 4 millimeters is considered abnormal.
It's just 4 millimeters. We're talking about an incredibly microscopic margin of error.
We are. Now, if the patient is on sequential HRT, meaning taking estrogen daily but adding progesterone for only a portion of the month to induce a planned withdrawal bleed, the baseline thickness is naturally slightly higher.
So the threshold for concern there is anything greater than 7 millimeters.
Right.
And if a patient's ultrasound comes back at, say, 5 millimeters on continuous therapy or 8 millimeters on sequential, it triggers a completely different set of rules. The patient is placed on the urgent suspicion of cancer pathway, the USCP.
And the timeline for the USCP is rigid. The patient must be seen by a specialist within 2 weeks.
2 weeks, wow.
At that point, the specialist moves beyond ultrasound to direct tissue sampling. They will perform a hysteroscopy.
That's where they insert a small camera directly into the uterine cavity, right?
Yes, to visually inspect for polyps or tumors. And they will take a physical biopsy of the lining to check for cellular abnormalities.
I mean, it sounds frightening, but it's designed to be a rapid response system. It takes the guesswork out of the primary care clinic and relies entirely on cellular data. It protects the patient from a worst-case scenario while rapidly clearing those who are healthy, but just having a prolonged reaction to the hormones.
It completely removes the burden of clinical guessing.
Right. So what does all of this mean for you, the listener? If we think about your healthcare journey, your general practitioner is like an exceptional general contractor.
Oh, I like that comparison.
Thanks.
Well,
They can oversee the entire project, manage the daily maintenance, and handle standard repairs beautifully. But premature ovarian insufficiency, complex oncological histories, severe neurological progesterone intolerances, and abnormal internal bleeding, those are fundamental structural crises.
they really are.
And when you hit a structural crisis, the general contractor needs to call in the specialized structural engineer, and that is the gynecological endocrinologist.
Because the specialist possesses the diagnostic tools, the nuanced pharmacological knowledge, and the multidisciplinary support network required to stabilize those complex structural issues.
And understanding these specific referral triggers gives you immense power. If you find yourself in any of these four categories, if your timeline is early, if your medical history is complex, if your brain is rejecting the treatment, or if you are bleeding past the 6-month mark, you do not have to endure endless, frustrating trial and error.
No, you don't.
Asking for a referral is not an insult to your GP. It is the evidence-based, medically mandated next step in your care.
And, exploring the neurological mechanisms behind things like progesterone intolerance leaves us with a really profound concept regarding the future of this field.
Yeah.
We have spent this entire deep dive discussing how different bodies and different brains metabolize hormones in wildly diverse ways.
Yeah.
As medical science pushes further into precision medicine, could the future of menopause care move away from standard prescriptions entirely?
Oh.
Imagine a protocol where, before a single patch is applied or a single pill is swallowed, a specialist uses personalized genomic mapping to analyze your exact GABA receptors and metabolic pathways, predicting precisely how your unique neurochemistry will react.
That would be amazing. Formulating the exact hormonal or non-hormonal cocktail your body requires based on your DNA, bypassing the trial and error entirely.
Exactly.
That is the kind of precision the future demands, and it's a completely fascinating thought to end on. Well, thank you for joining us on this deep dive. Keep questioning the standard playbook, keep advocating for the nuance your body deserves, and keep exploring. Until next time.